So I'll get going. Let me just say a couple things about the stress echo that was seen on the exam the couple times I took it. I think you can anticipate treadmill stress echoes, DSEs, and probably a bike exercise stress echo. There were 4 or 5 stress echo cases. They were reasonably straightforward, and the image quality was pretty good. Do not be surprised if one of them strikes you as being a normal study. So I would not be afraid to call something normal if you don't see any wall motion abnormalities. I think in terms of the ones that are positive, I think that the stress echoes were generally fairly straightforward. Single vessel disease or multi-vessel disease. So in my cases, I'm trying to give you some pretty basic ones, but I think Sunil and Steve might have maybe a little bit more complicated ones. So I'm going to concentrate mostly on coronary disease. If we can get rolling here.
Thought I was out. They pulled me back in.
It has absolutely nothing to do with the talk, but I just wanted to show that video. So I was trying to tie it in with strain imaging and things being pulled in or tethered, but it didn't work. So a lot of the newer equipment gives you views of the heart that I wish I had when I was learning echocardiography many years ago. And I'm just showing this just to show you the relationship that you can get between the various views. And you see, let's see. Which mouse do I use, the wired one or the wired one? Okay. You see here the relationship between the anatomic planes that is really nicely illustrated here. This one doesn't. This one here with the wire? Here we go, I think. Yeah, it's on the pad. There's a mouseopathy going on here. Okay. You know what? I don't think it's worth it. So let's go to the cases. So these are not the actual patients. These are just pictures of people that the patients remind me of. So it's totally idiosyncratic here. 66-year-old woman, retired phone company employee, heavy smoker, has noticed some exertional dyspnea of late. So here's a stress echocardiogram. This is the standard non-Mayo format. The stress echoes will be shown, as will all of the echoes, in the standard format. So you see rest on the left, 4-chamber view, 2-chamber view, and then stress on the right. I'll let you take a look at that for a second. No prior history of coronary heart disease or really any heart disease, and relatively new onset shortness of breath with exertion. Okay. So, can I have the ARS questions? Stress echo shows LAD infarction, no ischemia, RCA infarction with LAD ischemia by itself, or multivessel coronary disease. And while you're answering, can I go back? And play? Okay. So let's see what people think. What do my colleagues on the panel think? This is LAD ischemia music coming up. Okay, so multivessel coronary disease and LAD ischemia. Technically, this is LAD territory ischemia. Here's the cath film, and I'm being a little bit tricky here. She kind of has a very large diagonal branch with a very, very tight stenosis and also disease in the left anterior descending artery. But the stress echo, I was looking for LAD territory ischemia, and I think that's an example. This is an example of the type of stress echo you get. So again, you likely get one normal, and you'll probably get one single vessel disease that is fairly straightforward. And I would categorize this in the single vessel disease that is fairly straightforward. Okay, so I'm going to move on. So this lady actually underwent revascularization, and I'm not sure why this is not playing, but she actually did much better. Next case is an 82-year-old man who has very, very vague symptoms, not particularly great historian. No Thucydides, as we say in the 508 area code. So he has orthopedic issues, and we opted for a dobutamine stress echocardiogram for this individual. So you see the way this is displayed. This mouse is just plumb not working. Okay. Okay, so all right. Okay, so here are the 3 chamber views. Dobutamine stress echo. So the way we perform the stress echo is we have a baseline, we have low dose, typically 5 mics or so. We have a high dose, which you see at the lower left. Oh, great. Okay, so there's the peak dose, and there's recovery. So, would you like to see this again? Thought so. Let's go back. 4-chamber view. Two-chamber view. Three-chamber view. Diagnosis: normal, prior LAD MI, no ischemia, LAD ischemia only, multivessel coronary disease. No music? It's too late for music, I guess. Okay, very good. Multivessel coronary artery disease. So let's go back and take a look. We thought this was one of the more dramatic DSE examples. So I'll tell you what I think is happening here is if you actually look at the in the 4-chamber view here, you actually, it looks like you have a resting wall motion abnormality in this region here, which is the lateral wall. And then you clearly do not have any augmentation in that area there. So I would interpret this as demonstrating at least baseline circumflex coronary artery disease. And then the two-chamber view, I think, also shows some abnormalities in wall thickening in the left anterior descending distribution, which is this anterior wall here, which really does not get much better. Maybe it augments a little bit at the low dose. Maybe you're recruiting some myocardium there. But then I think at the peak dose, the left anterior descending artery distribution, I think, looks much worse. I don't know if my colleagues on the panel want to chime in here. Then I think, so at least at the moment, I'm thinking resting circumflex distribution problems and then ischemia in the LAD distribution. And this three-chamber view, I think, really shows it pretty nicely. Not only that, at the peak dose, not only is the left ventricular cavity not coming down in size as we expect to see with dobutamine, but may actually be, okay. Oh, good. Excellent. May actually be dilating. So we interpreted this as showing multivessel coronary artery disease, which you did also, and the angiogram was not particularly subtle. So again, I think this, in my opinion, again, I'll see what my colleagues think. In my opinion, this is the type of stress echo that you would get. There would be, one that is fairly straightforward. He has multiple lesions in his circumflex artery and his LAD distribution. I think likely had resting circumflex ischemia or infarction, and then I think LAD ischemia, certainly LAD ischemia, and probably additional circumflex ischemia with dobutamine. Let me show one more case, and then I'll turn over to my colleagues. 49-year-old woman with chest pain had an episode of chest pain after a very stressful encounter with her teenage daughter. I don't know what they're talking about here. It's usually no stress with teenagers. A history of depression, SSRI use. So we'll skip through her EKG just in the interest of time and show her echo. Okay, this is an exercise treadmill stress echo. 4-chamber view, rest. 4-chamber view, exercise. 2-chamber view, rest. 2-chamber view, exercise. Oops, I didn't want to show that. Sorry about that. So let's see, do I have the ARS slide? Let me just go. Sorry about that. I thought I had an ARS slide here. Anyway, who thinks this is normal? Not a lot of takers. LAD disease? Okay. Right coronary disease? Okay. Oh, here's our cross-sectional view. Let me show this again. Well, I'll tell you what I think. On the cross-sectional view, I think there's really an issue right here that I think is pretty dramatic. I see a little bit of, I see a lack of thickening here on the 3-chamber view in the anteroseptal region. So this concerns me for LAD territory disease. Let's see if I can go back a slide. 4-chamber view. I think, again, I'm concerned about the mid to distal septum. And I think while the anterior wall is coming in, I'm not sure I see a great augmentation in thickening. We interpreted this as LAD ischemia, which is, I'll show you, this is a very unusual anatomy. She had a cleft, basically. This was a CT angiogram. This lady had a cleft, a very unusual pathology in her left anterior descending artery, which we concerned about. We thought maybe the CT angiogram was leading us astray. And then she went on to the table of truth, as they say, and indeed had the same kind of phenomenon, this little cleft in her left anterior descending artery. So I think the stress echo really helped us in showing ischemia in this distribution, and she went on to have single vessel bypass surgery of the LAD. So I think maybe I'll turn the podium over to Sunil, and then if we have time, I have a couple of other cases.
Yeah, I would agree with Dr. Orajema that the stress echo cases on the boards are pretty straightforward, and we're just going to rock through a couple of quick ones here. No disclosures. I just want to go over a little bit about viability. Remember that dobutamine stress echo can be used to assess viability. We do it. I would tell you in my practice I use more cardiac MRI and PET scanning, but it can be done. And this is just one paper that showed the sensitivity and specificity. But what makes it more accurate is a biphasic response. So you have this type of response where you have resting global LV dysfunction, and then with dobutamine, it improves throughout the study. So 5 mics here, 30 mics here, and then recovery, it's kind of back to that global hypokinesis. This is a non-ischemic cardiomyopathy, actually. But what you really want to see is something like this, where you have a significant left ventricular dysfunction here, multiple regionals, fairly global, improvement at low dose dobutamine, whether that be 5 mics or 10 mics, but then it gets much worse. Once it gets worse, it gives you a good idea that it is an ischemic mechanism and that it is coronary disease, and this is that biphasic response that's the most accurate with regard to dobutamine. So I think we'll cover maybe these are real quick cases, but we'll start off. Soccer coach receives a red card. The new onset chest pain while biking. No cardiovascular risk factors. He's referred for an exercise echo. On the exercise echo, he does pretty well. 12 minutes on a Bruce protocol, 13 METs. Stopped because of fatigue, but the ECG was positive, and blood pressure response was blunted. So I can't really change the Mayo Clinic format here. Just remember the 2-chamber is the same. And the 4-chamber, if you're seeing a little bit of the aortic valve, it's more the infralateral wall. If you're not seeing the aortic valve in our view, it's more the anterolateral wall here, and the septum is the same. So here's rest and exercise. So just a little bit of fatigue is all he had. Give him maybe 10 more seconds, and then we'll take a vote. Hopefully I have the audience response. And this is just a little bit of different view. So here's a 5-chamber view actually. So this is more infralateral here now. But take a look at that, and here's an apical view. Okay, who thinks the study is normal, inferior ischemia, circus ischemia, LAD ischemia, or multivessel disease? I saw it there for a second, and I think, yeah, I agree with you. I agree with the majority of the audience here, indeed. I thought this was LAD ischemia, and we'll go back to it real quick. And I think this view really shows the apex really becoming abnormal, comparing it to the baseline, and then just take a look at this anterior wall here, comparing it, to the baseline. It's definitely getting worse. And then when you look at the apical view here, I think there's an abnormality here that clearly is worse than in this area. And then once again, the apex here really getting worse. And of course, I wouldn't say it was LAD ischemia without proof. Here's a lesion in the LAD. There really wasn't any circ or RCA lesions. And then after stenting, patient did well. So I think the majority of you got that right. I think you do need to recognize, the the regional abnormality. All right, we'll go to one. We'll go to maybe. I think if we'll just do. I don't know if I jump around though, you may not be able to stay with me, the audience response. So I better just stick in order. 67-year-old male referred for pre-op clearance for a 7-centimeter thoracic aortic aneurysm repair, just your everyday surgery. No cardiac history, no chest pain and dyspnea, but multiple risk factors: hypertension, hyperlipidemia, obesity, smoking, ex-smoker I should say. Lived a sedentary lifestyle. His exercise involved getting up from the sofa to get the remote controller. And he was referred for dobutamine echo prior to the vascular high-risk surgery. And here we go. So this is a more subtle finding, but watch closely. So once again, Mayo Clinic format. And this is a dobutamine. So our format's a little bit different. We don't show recovery. So this is baseline, 10 mics, pre-peak, and then this is the peak. Okay, so you see that right there. All right, we'll go to the next view. So this is a 3-chamber view. Compare the pre-peak especially to the peak and see if you think there's an abnormality. Okay, and now here's a 2-chamber view. Once again, it's especially helpful in the Mayo format to look at the pre-peak here in this 2-chamber to the peak. Okay, and the apical view. All right, time to vote. Normal, number 1. Inferior infralateral ischemia, number 2. Anterior ischemia, number 3. Apical ischemia, number 4. Excellent, excellent. I think that's correct. And I think the views that really show it best are this 2-chamber view really shows the inferior ischemia, I think, pretty well. Right there, the inferior wall. And then I think this view here as well, the lateral wall here is not normal, especially comparing it to this wall. Presumably we're looking at the same wall, and it's clearly a little bit worse. So I agree with the majority of the audience there. And the cath substantiated that. It was a kind of a circ dominant situation. There was some disease in the LAD. And here's the circ lesions that really show it really well. Multiple lesions sequentially in the circ, really diffuse disease. You know, in the right coronary was non-dominant and pretty small, but it had pretty significant disease. Pretty significant disease in the right and the circ. So, unfortunately, it wasn't a good story. My colleague, who's a very esteemed colleague, reasonably said we could try to get him through the surgery because there was such diffuse disease. He wanted to treat him medically. The patient actually got his repair. It was a pretty of a prolonged hospital course with a bit of a troponin rise, some AFib that developed, delayed extubation, as you'd expect with a 7-centimeter aneurysm. And unfortunately, it's not a happy ending. He made it out of the hospital with just a small MI, presumably small MI, but a year later died of stomach cancer. So not a happy ending. And I think I'll show you one more here, and then I'll turn it over to Steve. Let's go with this one. Bigger is not always better. A 70-year-old male with dyspnea on exertion and the typical cardiovascular risk factors. To evaluate his dyspnea, he's referred for an exercise echo. So here's the pre-study. 5-chamber, 4-chamber, short axis, and 2-chamber. And then there's the exercise, immediately post-exercise. You may get the idea of what we're talking about. Bigger is not always better. Okay, I think we'll take the vote. Normal? If you think normal, please leave the room. Maybe you should do nuclear boards. RCA ischemia, circumischemia, LAD ischemia, or multi-vessel disease. I shouldn't joke. I mean, it's tough. Excellent. That's excellent. And the persons that chose LAD ischemia, sure, that was the most prominent. But I think when you have, and let me go back to my slides if I could, just to show it one more time. I think the key thing is here the dilatation of the heart that occurs. See how the heart really dilates? Clearly there is LAD ischemia, but there's just marked dilatation of the ventricle, and I think even the inferior wall here doesn't do so well. This was the interpretation of my colleague, Dr. Garvin Kane. He thought it was multivessel, involved including the inferior wall, and a drop in EF. And that was substantiated here on cath, and there was some right disease as well. So I'll stop right there, but the dilatation of the ventricle, in addition to the LAD disease, now I think probably, Steve, with proximal LAD, you might get some dilatation, but usually it does mean multivessel disease, and I think for the boards, that's what they'll have you say.
Thank you. All right. Do you want me to push that red button? The red one? Yeah. All right, let me push this. If it blows up, we'll soon find out here. Let's see. Maybe yes, maybe no. I pushed the red button there. There we go. Lucky me. All right, perfect. Just one quick question. Someone asked about left bundle branch block. Is that a contraindication to stress testing or stress? The answer is no. I mean, that's a good indication to do a stress echocardiogram. Exercise myocardial perfusion imaging with left bundle, of course, you have the issues of that septal wall, but in stress echo, that would not be a contraindication. In fact, maybe a reason to consider doing it. So we'll go through cases. Each one of these cases has a particular tale to state. Again, we'll go in order so it follows the audience response. First is a pretty straightforward 56-year-old male. Presents with symptoms compatible with angina, Canadian Cardiovascular Class 2. Exercises on the Bruce for 7 minutes, 14 seconds, 8 METs. Peak heart rate is, as you see here, 148 beats per minute, and here's the peak exercise blood pressure, 188/102. Here's the 4-chamber view. So remember, this is an exercise. This is the apical 4-chamber view. The way we do it is we get 4 single beat clips of the 4-chamber view post-exercise. So here we see at rest, and here these are the 4-chamber post-exercise. I'll just briefly show you the 2-chamber view here. Rest, post-exercise. I think it's extremely helpful to get more than one single beat clip post-exercise. So this is a big advantage I think that we have. I think it's been very helpful that Dr. Feigenbaum had incorporated into our lab maybe 8 or 9 years ago. Very helpful. 3-chamber view. Peristernal long, peristernal short, and then the question is, what do you think? And we have the audience response, LAD, circ, LAD and circ, right coronary, or do you think this is normal? Boom, kidneys. All right, so either LAD and circ or LAD disease, which I agree those would be the 2 best options, but let's go through this. I'm just going to show you the cath so we know what the answer is here. The cath is that there's just significant lesion to the LAD. The right, we could play this if you want, but the right coronary looks normal. So this is just LAD disease when it underwent intervention. The point I wanted just to go over is we need to be able to label the walls So in this 4-chamber view, just remember the labeling of the walls. That's going to be important because it'll ask you which segments. And then when we look at the walls in the apical 4, here we see the walls labeling in the 2-chamber view. The apical anterior and inferior wall, to me, seem to be the most abnormal. If we go in the 3-chamber view, again, we see the apical anterior and the apical septal segment. So labeling the walls, and then we look back at this vascular distribution. And remember, so we were seeing this wall, and this wall. That's the LAD distribution. So that if they ask you, maybe not walls, but on arterial distribution, remember you have to relate the arterial distribution to the walls. And I just wanted to bring that point home because that's the question that they ask. I mean, they're going to ask that particular question almost unequivocally. I'll take this out because this was the change in that apical inferior wall in the 2015 guidelines switched to solely right coronary distribution. In the previous, it was right or LAD, so just remember that, at least for your exams. It appears like they won't have the 2015, so that apical inferior wall in the previous guidelines would be the right or LAD distribution, but as of January, it's just labeled in the LAD distribution for this apical inferior wall. Next case, briefly, of an 82-year-old gentleman presents with symptoms of chest pain, exercises on the Bruce as you see here. 171% of their functional capacity, peak exercise heart rate here, peak at blood pressure, and here we see the apical 4-chamber view, rest, post-exercise. So let's just take a peek of this. This was debated quite a bit in the lab. This is a case that was referred to me by one of my good friends and colleagues in our lab. This is the apical 2-chamber view. The apical 3-chamber view. So this is rest. This is post-exercise. We'll look quickly at the parasternal long axis view. Here's rest, and here we see post-exercise. And here we see the short axis rest. These are all post-exercise. All right, so the question is, what do you think? Is this LAD, circ, right, multivessel disease, or is this normal? So I'm really interested in people's opinion on this. All right, so most thought that this was multivessel disease, so at least thought this was an abnormal stress echocardiogram. This is how it was interpreted in the lab. So if we look at how this reader had interpreted the apical septum and anterior, they were thinking that this was all associated with LAD distribution disease. They had called this an abnormal stress echocardiogram. The patient did go to cath, and here we see the cath films here. There was really no obstructive epicardial coronary disease, and here we see the right coronary distribution, looks pretty clean. So the stress echo was abnormal, right? We all thought it was, and it was interpreted by a reader in our lab as being abnormal. I would agree, perhaps. I don't know what you guys thought about it. Yeah. So, but in the end of the day, there was no obstructive epicardial coronary disease. The point of this case is that this is, Dr. Seward would always say to us, it's not always about the anatomy, but it's always about the physiology. And we brought this up earlier, sorry about that. This is the characteristics and outcomes of patients with an abnormal stress echocardiogram. But at cath, they had really no disease or mild angiographically significant disease. And the bottom line is, it really didn't matter whether they had less than 50% stenosis or really a true positive defined as at least a 50% lesion. Their prognosis with respect to survival was equally poor, whether this was exercise, a little worse, as you can imagine, with dobutamine, simply because there must be a reason they couldn't have exercised for dobutamine. So again, an abnormal stress echocardiogram, they go to the cath lab and the cath guys come back and say, oh, you dummies, you got this wrong, they have no epicardial coronary disease. I say, thank you very much, but the patient's prognosis remains poor. Because there are other reasons, as we discussed in the lecture a couple of lectures ago, to have abnormal stress tests. that may be ischemic, but in the absence of epicardial obstruction. So just because there's no epicardial disease doesn't mean that the patients have a better prognosis. It's not always about the anatomy. Again, it's almost always about the physiology. Here's a 62-year-old gentleman, orthopedic limitations to exercise, and was evaluated for atypical chest pain. So 62, atypical chest pain. We come back to these appropriate use criteria. This is for the diagnosis or detection of coronary disease. This isn't a perioperative risk stratification thing. So this would be an appropriate indication for stress testing. And let me share with you this study shared from a former colleague of mine, I guess colleague Dr. Chandra, lent me this case. So it's a bit of an older case, so you might have seen this before. But here we see that this is a dobutamine stress. So rest, low dose, pre-peak, and peak. I think that's very valuable to do pre-peak and peak imaging because, as we discussed, often the double product is a lot lower at peak than at pre-peak. And you see the abnormalities in the pre-peak images, not in the peak images. So that's the way we look at this. So take a look at this test. Parasternal long. Here's the parasternal short. So this is rest. Just look at rest. Here's peak. Okay? Rest, low dose, pre-peak, and peak. Okay? Two-chamber view. Rest, get pre-peak and peak. And so I'm just going to give you, this is a whole bunch to look at, but just take a quick peek at this. And then this, remember, is a 62-year-old gentleman, atypical chest pain. So what do you think? I don't know, do you have audience response? Did you make it for this one? Yeah. So what do you guys think about that particular case? Okay, so most people said three-vessel disease. And in fact, this is how it was reported in the lab, is the patient had at least multi-vessel disease. Let's go back and take a look at these images. Clearly here, they just look at the short axis. It seems to dilate from rest post-exercise, or very little augmentation or reduction in end systolic volume in any of these views. And it really looks for all the world to be multi-vessel coronary disease. So if the patient went to cath, these are still frame images at cath, and although it's not completely normal, there's no really hemodynamically obstructive epicardial coronary artery disease. So in this 62-year-old gentleman, the piece of information I didn't give you was this, that here's the blood pressure that was obtained post-exercise, 205 over 120, marked hypertensive blood pressure response. And this is hypertensive response. This is an exercise, but is a potential cause for new wall motion abnormalities. And they looked at 548 patients. They were cathed within 4 weeks. 132 had a hypertensive response, as defined here. Systolic blood pressures in men and women, and a diastolic pressure increasing by 10 or to greater than 90. So that was the definition of the hypertensive blood pressure response. And in those that had a hypertensive response, 22%, or about a fifth of them, were false positives or didn't have obstructive epicardial disease. Those that had a normal blood pressure response, only about 12%, 10 or 12%, were deemed to be false positive. And so the concept here is that an excessive rise in blood pressure during exercise is associated with a greater likelihood of new or worsening abnormalities with exercise, or in this case dobutamine, which may be observed in the absence of angiographically significant coronary stenosis. So we all thought it was abnormal. We would have called that, but the blood pressure response may have been the reason for that. I can stop at any time. Okay.